So thank you to everyone who's joining us for the session today. We've got some people in the room with us on Click Meeting, and we'll also have some people join us live on Facebook as well. For anyone who hasn't met me before, I'm Christie. I'm the Head of Patient Services at the Foundation, and I'd also like to welcome along Professor David Jones. Thanks for joining us again, Dave. It's very much appreciated.
It's a pleasure. And just can I apologise in advance? I'm doing this one from home, so one of 3 cats may join in at some point, and undoubtedly one of 2 cockatiels will chirp along because they don't half love hearing conversations. So if you do hear cockatiels in the background, you're not hallucinating. It's there you go now. So
and there's every chance my little dog might make an appearance at some point as well. So all inclusive.
We might be okay with the cats because it's afternoon, so it's time to go to sleep. But we'll see how we go.
So just before we start, I just want to do a wee reminder that these Q&As don't take the place of a consultation with your own clinician. So we're aiming not to provide medical advice, but general medical information. And also, please just remember that Facebook's a public environment, public forum, so just be aware what you're typing in the chat box there. And you're welcome to join us in Click Meeting here for the privacy of the room with Professor Jones and I. I'm going to get started on the questions that we've had sent in, but I'll also keep an eye in the chat here in Click Meeting and also in Facebook. So if you have any questions, please just pop them in there and then I can pick them up there as well. Okay, so we can just make a start on the questions that's been sent in for us just now, Dave. So first question we've got is, how long after starting URSO should your numbers start coming down, and will you also always have fatigue?
So what was that? How long after starting URSO?
Should your numbers start coming down, was the first part.
Okay, so that's a really good question. So there's kind of a short answer and a long answer. So the kind of long answer is that formally you need to be on it for 12 months before you know the nature of the response. So in a way, when you start URSO, that's it for 12 months at the moment, until you see the nature of your response. Now, the slightly longer answer is that actually you should see an effect long before 12 months. So 12 months is the point at which you've probably seen the maximum effect. And you will see most of the effect by 6 months, certainly, and you will see a good proportion of the effect by 3 months. So it's really first 3 months, followed by the next 3 months, followed by the next 6 months is the kind of sequence of you seeing improvement. So increasingly, I think we're not going to be sticking to that 12 months, because if you've got an alkaline phosphatase of 1,000, very high, and you start URSO, and 6 months later you still have an alkaline phosphatase of 1,000, then realistically it's not going to go back to normal over the next 6 months. So I think the 12 months can be a little bit arbitrary. And the key thing here is to get the right treatment into the right person at the right time. So, and try and avoid delays, because we know delays in kind of diagnosis and then delays in starting treatment, all of those delays add together. So, and I think delaying, an arbitrary waiting 12 months when it's very clear what's going to happen. By the same token, if you've gone from, an alk phos of 1,000 to 250 in 3 months, then it absolutely is worth waiting a year, because you've clearly had a significant response to it. So what happens early on really predicts what happens down the line. So I think that's going to be the direction of travel, a little less sort of rigidity. Second part of the question about fatigue is probably, to me, the number one issue. I mean, that's what the number one issue that patients talk to me about. As we've talked about many times on these calls, we have a specialist clinic to manage symptoms. So about 2/3 of the people who come to that clinic are people with fatigue, about 1/3 with itch, and actually very few who've got both, interestingly. And of those 2/3 of the people who come to a clinic with real problems with fatigue, I can tell you they are all on URSO, and they've all responded completely to URSO. It's really interesting. And what that tells us is that URSO doesn't improve fatigue, and I think we all know that. I wish it did. It doesn't. And so we just need to be aware of all of that. Do other treatments improve fatigue? We suspect not. although they've not really been looked at properly. And I think you're going to need specific treatments for fatigue. So in the same way as itch doesn't really get better with the standard PBC treatments, it needs its own treatments. I think the direction of travel is specific ways to be able to manage fatigue. I think one of the important things is that you can do an awful lot yourself to help mitigate the effects of fatigue. The two important things are really important are keeping as active and exercising as much as you can, because that helps the physiology of how your muscles and things work. So the foundation are very keen on a concept called movement as medicine. Palak Trivedi, who many of you will know in Birmingham, has done a very nice trial with one of his colleagues looking at exercise, and it really helps with fatigue, although a lot of people feel it's very difficult to start with. So you can, by exercising, really help yourself. And the other thing that's really helpful is listening to your body. So getting a rhythm for when you feel tired, the situations you're going to. Are you one of those people, like most PBC patients, you're fine or much better in the morning, you kind of run out of energy during the day? Then just be aware of that and adapt what you do. If it's more of a brain fog type of mental fatigue, then don't be worried about keeping lists of things, sort of tricks that you can do. So really get a feel for your body, a feel for the rhythm of it, and work with it. Don't work against it. So those will be the top two tips. Do I hope that we will get a specific treatment for fatigue? For sure, because I think that's the largest need. We're not there yet, but there are a number of initiatives, and there are trials in this space already, and I think it will be the next thing. And I think one of the bits of real success that's come out from the work of the foundation recently, this came out at the summit meeting, is the interest of industry in fatigue as a target. And I think industry, ultimately the people who make drugs are drug companies, and so the fact that they see this as important, they're listening to patients, they're listening to stories, they see the problem, and there's a lot of effort and energy going into it, which makes me very optimistic about the future. Although even if we had a magic treatment available tomorrow, people are still going to need to exercise to get back to full fitness. So it's never going to be a magic tablet that makes it go away. It will be part of a more complex solution. But with the best will in the world, URSO is not part of the solution. And if you don't feel the fatigue reducing with URSO, that doesn't mean it isn't working. URSO does something different. It's a very valuable thing it does, but you need to have an approach to the fatigue specifically.
To manage the symptoms, yeah. No, that's great. There was a comment there on Facebook just when you mentioned about a fatigue clinic. The fatigue clinic is at your unit, isn't it, Dave? So there's not necessarily a fatigue clinic available at each of the units.
Okay. So yes, so I think, and I'll tell you a little bit about what we're doing with that. So we set up a symptoms clinic because many people will know it's a thing that I have been very interested in as a PBC doctor and very worried about in terms of the patients. And it seemed to us the big gap. And in a way, as we got better and better at treating, as we got better and better at treating the disease itself, URSO and bezafibrate and obeticholic acid and other drugs coming along, so there was more of a disconnect between what people felt and what the doctors thought was going on. So people were being told, oh, it's going really well, your blood tests are normal, isn't that great? And people were saying, but hang on, I don't feel any better. And this led to one of the more kind of unfortunate things, which was a sense amongst doctors, well, you can't really be fatigued because look at your blood tests. Well, we know that these aren't connected things. The severity of the disease and the severity of the symptoms are not connected, but we know that in lots of situations. I always say there are people who have a heart attack which is totally silent, you get no pain at all, and there are people who get really bad angina and have completely normal coronary arteries. So the symptom severity and the disease severity are not connected. So it's not helpful for doctors to say your blood tests are normal, so how can you possibly have fatigue? That led us to think, and Jess Dyson, who a number of you will know is a sort of colleague of mine, it became very clear that actually there were two kind of types of people. There were those for whom the risk of the disease was the big thing, people maybe with cirrhosis or heading towards transplant. And there were those people for whom symptoms were the big thing. And they actually needed quite different things and a different approach and a different conversation. So what we ended up doing is not splitting the clinic, but we ended up having two sides to it, if you like. And so it was just, we needed to have more capacity, seeing lots of people. It just made sense to have a clinic that the pace was a little bit different, because you're looking at different things over a length of time. And that's where the idea came from. And because we're academics, it's, what's the use of a professor? Well, you have a certain latitude to do things differently. So because we are innovators, we got permission from the trust to set up a clinic to do that as an experiment. We didn't know if anybody wanted to come to it or if it was useful or all those things. Now, our waiting time is 9 months. So I think that tells you that people find it very useful. So I think there's an important lesson with it. What we're doing, however, is that's not fair, to people who live in the other end of the country. And so what we're doing at the moment is pulling together all of the materials and the approach that we use into a pack. We call it My 3 Steps, because we talk to people about the steps they can take to really start to crack this. We are in the process of getting that printed up. And then what we're going to do is give that away to anybody who wants it, this is really something that specialist nurses do very well. Kath Houghton, who many of you will know in our clinic, runs a large element of that, because it's about thinking and developing approaches and stuff like that. So what we're going to do is give away the materials to anybody and everybody, and then we're going to organize some online training for clinicians. So the idea is that that basically any centre would be able to offer this approach, because they'd have the knowledge, the approach, the materials and things. So see if that's helpful, and then be able to kind of do refreshers for people. So it wouldn't be me, but it would kind of be my view of the world. So we'll see how that goes. And certainly we've had lots of people in other clinics really interested in it. So there are lots of colleagues around the country who've asked for this. And so our colleagues in Advans, who sell obeticholic acid in the UK, they're very kindly going to print this up as a service to the patients. And basically their reps will give it out to clinicians, and it's free to anybody. And it will include we produce a lot of leaflets and things, signposted into the app, so on and so forth. And it's really just a bit of a toolkit. People will leave with a kind of folder of resources and approach, and a book that's about My 3 Steps and progress with it. So we'll see how that goes. But the whole thing, I think, has been really successful. And we've had some. It's hard. It's not straightforward, but we've had some real conspicuous wins. So with people coming back and saying, "That's it, it's cracked it. I feel, fabulous." But what I would say is that what that thing is that cracks it for that person, it differs from person to person. And so it's a case of working through it. So this isn't a cure, it's an approach, but the approach is about helping you to live the life the best you can. But it's also an approach that kind of recognizes that you have to maybe run through a number of aspects to kind of find, until you find the answer. You have to open a number of oysters until you find the pearl.
Yeah.
So that's My 3 Steps. That's what it's going to be. And it's just going to be hopefully really helpful. So we've got a whole load of leaflets that we've written already, but I've done 3 more this week on depression and anxiety, on sleep, and on the menopause and HRT, which just follow on from the questions that we're getting asked all the time. Yes, so basically anybody who wants it, it'll all be available. So there's a question about the pack.
It's been available to clinicians or wider to members of the foundation,
anybody. So it will be downloaded. It'll all be available as a pack. It will be downloadable. We'll get Advance to drop off, a huge pile of them, but it will be downloadable PDFs from the internet. And what we can do, I think, if people are keen to take it on themselves, we can do a patient kind of orientation webinar. What we've all learned with COVID is that you can do, these sorts of education things very easily. So that will be a really interesting way. And the app will be a perfect way to track your symptoms. So as I say, this is very information rich. It's very easy for us to produce more information, if you like. So it's going to be a folder that will have the leaflets, we'll put the leaflets into it that are relevant to you, based on your problem set, so HRT in the menopause may be less relevant for the men with PBC, for example. So, and it'll be there. So it's all designed to just help you find your way through it.
We're actually doing some work on the revamping the PBC app at the moment. And a big part of that will be PBC and me. So there'll be lots of ways and really easy ways to record your symptoms and things there. So that would match up really well with
and I think one of the people will know from, hearing me talk and from the book and things like that is one of our mantras is own the problem, own the solution. So this is the looking inside yourself, what isn't working for you, and then owning it, taking it on, conquering it. And the reverse of that is don't give in to it. It's kind of, and the my 3 steps, we alighted on that because that they are yours, they're not mine. So what are you going to do in the next 2 months that that will make a difference? And I remember, I was talking to a lady, just this week who, was really struggling with it and very muscly type of fatigue. And she said, that's it. We talked about this. That's it. I'm going to exercise. I'm going to damn well do it. And so she's now exercising and she's doing really well with it. And then we talk about ways of sustaining it, because we all know it's easy to exercise on a sort of nice day in the summer. It's, for those of you who live in Scotland or the north of England, the sun barely comes above the horizon in the winter. It's cold, it's rainy. It's a bit more difficult to do it then. So sustaining it is those things. So, and then we had another chat about it. And she done Couch to 5K, which those of you who've ever come across it, that's a free download from the BBC website, and it's really good. And what it does is it's a program that literally does what it says. It takes you from not doing any exercise at all to being able to do a 5K race. And what they've got is a number of celebrities. So you can and who talk you through it as you're doing it. So you play it on your earphones and your smartphone, and they tell you when to walk and when to run and stop. And it's very, it's neatly done, and it's quite funny. And you kind of have, these celebrities talking to you, which is a bit strange. But then of course, why 5K? Why 5 kilometers? Well, that's the distance for park run. Many of you will heard about Park Run, which is a brilliant thing, which was just set up as a kind of community thing, and it's in place around the world. So anywhere in the world, you can look up where there's a park run. It's always a Saturday morning. It's always 9 o'clock, and it's a community of people who do a 5 kilometer run or a walk. And it's ordinary people. It's people like you. And the beauty of it is there's a kind of community of it at the back. So you'll have competitive runners who set times and things, but you will have somebody at the back, and there's a kind of community of people doing it. But they always have what's called a tail walker, who is one of the team. So you will never be last, right? You'll never be last, and you'll never be left behind. And it's actually brilliant. So she's now going to go off and do Park Run with her son. And I just think it's having done it, got going herself, now that kind of structure of doing it. And actually one of the things where it went badly wrong in COVID was slightly bizarrely, Park Run was shut down when it's outdoors. And actually a lot of people lost exercise and things as part of that. So these are the things we want to highlight. It's all very well and good me saying, go off and do this, that, and the other. You need to be more practical about practical suggestions. One of the things I've always talked about with this, so Mo, you are familiar, having watched these, that is the constant battle between me talking too much and Robert arguing for quickfire round. So you're going to come to the quickfire round very quickly, but I've talked about this before on these calls. A good friend of ours called Mike Tranell, who's an exercise scientist, he came up with the term movement as medicine. So he's a good friend of the foundation, but does the science of exercise. And he's at Newcastle University, and a number of us went out to Malaysia, where Newcastle have a campus. So we all flew into Singapore Airport. And there's a brilliant bit of film he took on his phone, which is all of these senior university people standing on a moving walkway at the airport. And he is walking along next door, doing a commentary on all of these lazy people not walking. And his point is, He arrived at the immigration at the same time as us, but did so, for those of you who know, Singapore airport is huge, but he'd done his steps. And he set off at the same time, he arrived at the same time, didn't take any time out of his day, but he'd done his steps at the end of it. Movement is medicine. It's fitting it into ordinary life. So, and that's why things like these, so this is a Fitbit, for those of you who like such things, other brands are available. I'm not an influencer or a brand ambassador. I wish I was, but sadly not. These are really simple ways. So you think to yourself, how do I know if I'm doing enough? If I just kind of get off the bus or stop early and walk, how do I know if I'm doing enough? These cost 30, 40 quid. Most people have a smartphone these days that they have very accurate step counters. Count your steps. Don't have an arbitrary target. It gives you an idea how much you're doing. So it's a really good way of making sure you do enough of your kind of what I call ambient exercise. It's kind of exercise fitting into the normal day.
Mm-hmm. Just picking up on the fatigue part, there was a couple of questions came in when you were talking about fatigue, one on Click Meeting and one on Facebook that's the same. Is coenzyme Q10 good for fatigue?
Yes. So when people see the leaflets, one of the resources we're going to have in the pack is around vitamins and supplements, because many people are interested in those and they have a feeling, which I think is a very interesting one. I've had lots of people say this, that something just doesn't feel quite right, feels like I'm missing something. Now, the meaning, significance of that can be difficult to determine, but it is quite a common sense. And we do know that liver disease impacts on metabolism. That's what it does, and your absorption of things from your diet. So in the background is a sense that kind of makes some sense. So there's a thing called coenzyme Q10, and what it is it's a vitamin. Okay, it's a straight vitamin. It's not A, B, C, D, E. It's one of the, isn't called a vitamin, but is, if you like. And your body needs it to make energy. So when your cells turn glucose and oxygen into water, carbon dioxide, and energy, that's basically metabolism. You need coenzyme Q10 for the process, okay? Because it shuttles components of the pathway. It's a bit like those automated buggies in car factories that carry the car around from one bit to another. You need that. And it gets depleted in PBC. It can be short in other people, but it leads to a reduction in energy, okay, because you can't generate as much. Now, actually, a lot of athletes use it because it helps them train. You can train a little bit more because you're a bit more effective at generating energy. And we did a trial in PBC probably 20 years ago now, which showed it was not dramatically beneficial, but it was beneficial. And it allowed you to exercise a little bit more. And we know that exercise is beneficial. So it's kind of not the solution, but it's part of the solution. And it's very cheaply available. It's completely safe in PBC. It's very cheaply available. You can buy it off Amazon. You want to take a reasonable dose. So we recommend people take about 100 milligrams. You can buy it in 10 milligram tablets. Do not buy 10 milligram tablets and take 10 of them. That's an expensive way of doing it. You can get 100 milligram tablets, cheap as chips on Amazon. It's all made in the same factory. It doesn't matter. You can get it expensively from the high street, but don't bother. And a lot of people take it, and it contributes to their ability to kind of push forward with the things that they want to do. So like a lot of these things, we don't have any miracle treatments, but we have things that all add to the picture. And I think things that help you exercise more are very helpful.
We've got someone asking on Facebook if coenzyme is safe if you have low blood pressure.
Yes, it is. It's also it's used by the heart. It's used by the heart doctors in heart failure. It protects heart muscle, improves the function of heart muscle, which is no surprise because it improves the function of muscle. I've just seen there's a question. Any tips from Caroline? Any tips for dealing with muscle aches and pains after exercise? Q10, actually, just not to argue. I have no shares in Q10, by the way, just in case you wonder. The biggest giveaway for us, for people who will benefit from Q10, is not just muscle, feeling like the batteries are run down in your muscle. It's when your muscles actually ache, and they ache because you produce lactic acid. because of the way the metabolism's working. And what Q10 does is helps you metabolize the other way, which is in the mitochondria, which doesn't produce lactic acid. So when we're deciding which of the sorts of things that we try for fatigue, how do we prioritize them? For me, if you've got batteries running down, so we talk about batteries running down fatigue, which is very peripheral and muscle, and we talk about brain fog, which is very central and brain. We think it's energy issues in both the brain and the muscles, but it's just the way it impacts on people. So the moment anybody had aches and pains after exercise, we would always consider Q10. I mean, magnesium is a really interesting thought. A lot of liver disease, I mean, magnesium behaves in a very similar way to calcium. So we're very familiar with calcium and its role in bones, but it also plays an important role in how muscle works. So actually it's calcium being released that triggers muscles to behave like muscles. And whereas magnesium isn't particularly laid down in the bones, it is an important part of how muscles function. Now, we know that calcium shortage is an issue in PBC patients. We know that osteoporosis is to do with vitamin D deficiency, which is common in our population because we don't spend as much time outdoors as we would like to, and it always rains. People with different skin pigments and so on. So we as a population, as a world, in certainly Northern Europe, lack vitamin D. We don't measure it in people anymore because there's frankly no point because everyone is short. Hence vitamin D supplementation. But vitamin D plus calcium will help pull your bones out. But actually, magnesium shortage can go along with is also caused by vitamin D, and people don't take it as a supplement. So it's a really good point. It's one of the ones we're just going to start to have a little think about, and just should we be suggesting to people that they make sure they have enough magnesium going in. In practice, you need a really good multivitamin and mineral preparation, which will include that. I'll tell you, sorry, Mo, you failed on quickfire round. I don't know what.
We're on question one. It's turned into a bit of a fatigue special, but to be honest, lots of the patients will be really interested in that.
Yeah.
And I've got a couple of questions on.
I'll just tell you a little.
So we'll get them as well.
I'll tell you a little story, which is that I've now been. I know this, people are going to find this literally impossible to believe. Literally impossible to believe because I'm so youthful and vigorous. But I started doing a PBC clinic in 1991. And I'm still seeing some people I first saw in 1991. So anybody thinks you can't have a very long and healthy life with PBC, you can. Attention to detail. So I started this in 1991. So when I look at PBC, it is in the same population, same part of the country, same clinic setup, but over 32 years. So differences between then and now are very conspicuous. But I'm the same and the clinic is the same and the north of England is the same. So I always ask myself, what's changed? What's changed here? And there are two overwhelming differences, three overwhelming differences between now and 1991 and now. The first is over half the people we used to see then were jaundiced. Okay, half the people had high bilirubins, half. Yet now it's in our population, it's 2 or 3%. So something we're doing is changing the progression of this disease. Okay, so I don't know, is it URSO or bezafibrate or OCA or all of those things or whatever? Something is different because it's just completely different in terms of that aspect. So that's the first one. The second is osteoporosis has almost completely disappeared. So in those days, you used to see people with multiple fractures, two hip fractures, a knee fracture. It was awful. And yet we almost never see it. Now, why is that? It could be we're better at screening and treating it. I think it's URSO, actually. Maybe calcium and vitamin D. So we still look for it, but it's almost disappeared as a problem. Okay. And then the third one is that fatigue is much, much, much more prominent than it used to be. Now, what does that mean? Well, it could be that we just didn't see it before, and that's possible. Okay, there's observation bias is that we just weren't looking, our eyes weren't open, so that's possible. Okay, a second is if you're got a bilirubin of 200 or 300, to be honest, you've got other problems to be aware of, and fatigue may be a lesser problem compared to the really significant ones with your liver disease. So it may be that people are now well enough to feel that their fatigue is a problem. That's perfectly possible. Okay, but remember, I'm the same person, so that's the constant in all of this. But we do two things differently to what we did in 1991. And in 1991, everybody got an injection into their muscles every 3 months of vitamin A and vitamin D. Okay, everyone. Sheila Sherlock came up with it in the 1950s. It was standard practice. They'd come and see us, they'd go and see the nurses, and they would have those injections, and we never saw fatigue. Okay, now, given what we talked about with vitamin D and calcium, vitamin A, and normal cell function, is that part of why we now see fatigue? It keeps coming back to me. So it's one of the reasons why, and there are people around still who swore by it. I've never been the same since getting these injections. We stopped giving them for the very simple reason that the injections stopped being available. It wasn't for any other, it wasn't cost or anything else. They just weren't made anymore. So we had to stop doing it. But I just have this sneaking suspicion that there might be something in vitamin A, vitamin D, both of which are short in PBC, and both of which seem to disappear when people got injections of them. So that's old Mother Jones's, theory based on 32 years of doing it. That's the main thing that's different.
We actually also had a question when we were talking about the Q10 earlier on, that one of our patients on Facebook has said that they pay to get B12 injections to help with their fatigue. They don't mention if they feel it helps their fatigue, but what are your thoughts on?
Yeah, I would be, you need to be a little bit cautious because you don't want to have too much B12. So B12, so B12 you need for two things. One is to make red cells. So you need it to be able to turn iron into hemoglobin. So that's important. And you also need to have folic acid at the same time. You need to have as much folic acid as B12, right? You also need to have B12 for normal function of the spinal cord. So people with B12 deficiency will get neurological problems, even dementia and things like that. Mm-hmm. However, the more B12 you have, the more stressed the folate level is. So you can have too much in the way of vitamins. And so I would be cautious about having B12 injections unless your B12 level is low, in which case they're very valuable. So they are not a sort of tonic. For those people who collect obscure facts, the only piece of a polar bear that you can't eat is its liver. Okay, you can't eat a polar bear's liver, and the reason is because we talked a little bit about how low vitamin A was a problem, but very high levels of vitamin A are toxic and in fact can be fatal. Because of the amount of fish polar bears eat, they concentrate huge amounts of vitamin A into their liver. Now, we all might have thought that there were, eating a polar bear might have some other more specific risks, like catching a polar bear. But actually, and they knew this from one of these, these expeditions to the Antarctic, showing his ignorance, to the Arctic, where these ships got sort of frozen in, and they caught and ate polar bears, and they were fine until they ate the liver. The local natives, the Inuit, told them not to eat the liver because they knew not to, and they were fine until they ate the liver, and then they all died. So that's obscure fact of the day. So too much. Bottom line is, too much in the way of vitamins can be as problematic as too low. But B12 supplementation, if you've got low B12, you shouldn't need to pay for the injections. The only caveat I would say, this also applies to iron. And also a little bit thyroid, is that we don't quite know how to handle kind of borderline values. Okay, so there is a very good colleague of mine here is really interested in the role played by just normal but basically low thyroxine in terms of things like fatigue and heart failure. So essentially, it's kind of in the normal range, but it's on the low side. And the question is that low for you or is that normal for you? And if you've never had your thyroid function mentioned, you don't know. And there is a theory, there is some evidence that actually in fatigue, iron is just beneficial to everybody with fatigue, irrespective of whether they're iron deficient or not. And that tends to not be a very productive thing to do, because anybody who's taken iron tablets will know they're pretty horrible to take and they cause a lot of gut disturbance. But there are now injectable forms of iron which are really person friendly. And I've certainly seen people get a disproportionate improvement in their fatigue by getting what we call colloidal iron. So there may be a possibility that a kind of marginal B12 is low for you and that actually you get benefit from it. So I have to say we take normal ranges with a bit of a pinch of salt. And if it's not plumb normal, we often will supplement it a little bit just to see if it's beneficial. So all of this is good reason why a very good multivitamin and mineral, you can get them in supermarkets, don't pay a lot of money for them. A good multivitamin is helpful, and then get some Q10 on top of that. Normal multivitamins won't include Q10, so get some on top of that. So it's the first thing we recommend because it's easy for patients to get a bit depleted.
Brilliant. 2 quick questions on Q10 before we move on, because there was quite a lot of interest in that. Is it safe to chew Q10 for those who don't swallow pills, i.e. does it need to be time release?
No.
No concerns about that. Great. And one last one on that. Would Q10 be okay if the patient has cirrhosis and waiting for transplant?
Yes.
Yes, perfect. Thank you so much.
Yeah.
Right. Move on to our next one. Patient who has permanently swollen ankles, is there a connection with PBC?
Yeah, so you, yes, so 2 connections. One is if you have a low protein for whatever reason, so one, liver makes protein, so if your proteins drop, then you can get sort of fluid going out into your ankles. The other one is that one of the things we end up talking about quite a lot is the autonomic nervous system, which is the bit that controls your blood pressure, heart rate, all of those things. And that's often abnormal in PBC. It's part of fatigue. So it's often why people with PBC fatigue often feel a bit dizzy when they stand up. And obviously, one of the functions of the autonomic nervous system is to fluid back from your legs back to your heart. And so it may be connected to that. However, it's important, swollen ankles is a very common problem in the population. People who are on their feet, too much during the day, or, a little bit, the muscles aren't pumping, blood back to your heart, So there are reasons why, varicose veins, there are reasons why people can get swollen ankles. Practically, they can be a problem because they make your legs heavy. People often talk about heavy legs. And if you've got heavy legs, you won't exercise as much. So actually it is a little bit counterproductive. And so it's nothing sinister or serious. And we tend to often, if people are complaining about their legs being heavy, we often look at using a very low dose of water tablet just to get on top of the fluid a little bit to just help people. Because actually, remember, the reason why guardsmen don't fall over on, or do occasionally fall over on coronations and things, is that you need the muscles to pump the fluid back, and if you're not doing anything with the muscles, you don't. So if you do get heavy legs, you aren't walking, then it will just make it worse. So if a little bit of water tablet, you end up peeing lots more, so you're walking to and from the toilet. So it's kind of a package deal. So it will allow you just to be able to get a little bit more mobile, which will tend to sort it out.
Okay. We've got a question about coffee. Does decaffeinated coffee have the same positive benefit effects as caffeinated coffee? I think that's the general benefit for the liver, isn't it, for coffee?
Yeah, there's a kind of meme out there that caffeine is good for your liver. I think it's a nice story. I'm not particularly convinced that there's evidence for it. I mean, people have looked at caffeine specifically in a number of liver diseases and can't really see any benefit. I mean, I'll hang on to this one. I chain drink coffee, so I'll keep citing this one. So I don't think there's any harm drinking coffee. There is this evidence. I'm not sure what within coffee is beneficial. I think that's important to say. So obviously, in in coffee, there are lots of different things. It isn't the caffeine that gives it its colour and its taste. So there are lots of things in coffee, and including caffeine, and caffeine is taken out by the decaffeination process. It also will take out some other things, which is why decaffeinated coffee is a little bit bland. So the short answer is I don't know. But I would be just a little bit skeptical about the specific benefits of coffee. In PBC terms, let's bring it back to PBC, there is a problem with caffeine, which is that sleep is an issue with PBC patients. It's a big factor in fatigue and cognitive symptoms because poor sleep makes those worse, and people can be very sensitive to caffeine, and that can be a factor in stopping sleep. So if you are struggling to sleep and have got fatigue, be really cautious about any caffeine, pretty much after lunchtime, if I'm honest, because it will keep you awake, and that will contribute to it all. And please don't do what British people do. British people are wonderful, aren't they? They do mad things, but it is the most British thing imaginable. What do you do if you can't go to sleep in the middle of the night? You go downstairs and you put the kettle on and make a nice cup of tea. And tea has more caffeine in it than coffee. It is literally the worst thing you could possibly do, other than drinking Red Bull. And that's bad for three reasons. One is it's ridiculously expensive. Two, it tastes foul. And three, it's got even more caffeine than coffee. Other soft drinks are available.
Might get a Brandon deal there as well.
Well, I just want to be an influencer. That's me.
We'll keep trying.
Yeah.
So the background to this one is patient was diagnosed last November, and over the past few months they've noticed joint and muscle pains at different times. Some days are okay, mainly knees, thighs, sometimes shins and shoulders. They're taken or so. Can you offer some advice on how best to handle the pain?
Yeah. So yes. So really interestingly, we when we did some of the work using the PBC, deriving the PBC 40, so many people on the call will have filled in the questionnaire that starts out with lots of symptoms, then talks about itch, and then talks about fatigue, and that's the standard tool for assessing symptoms in PBC. And it was devised by interviewing a whole series of patients and finding out what they said, putting all their statements into a computer, and then identifying the themes that came out from it. So that's how you develop these measures. When we did that, we've got 20 years ago now, when we did that, there were some surprises in it, okay? There were things that we knew about, itch and fatigue and so on, but there were some things we really didn't know about. And actually, one of the things we didn't know about that came out with this was pain in the bones, which almost no PBC doctors ever talk about, but came out loud and clear in this. And actually, when we did some work on what impacts on quality of life, pain in the bones comes out as a big factor, actually. It's very interesting. So it's one of the neglected symptoms of PBC, bone pain. And I suspect, it goes back to what we talked about before, I suspect it's related to the calcium, vitamin D and magnesium potentially. And so I think it's an important reason to make sure you have plenty of that. In addition to the bones, you also get joint problems in PBC. So that's quite common. It's part of it. It's a similar distribution to rheumatoid arthritis, but it's not rheumatoid arthritis. You don't get the destructive, people will be familiar with what the hands of people with bad rheumatoid arthritis look like. You don't get that in PBC at all. You get the same sorts of joints, small joints in the hands, hips, knees. And it can be irritating and uncomfortable, but it is rarely more than that. It is associated with dry eyes and dry mouth. So we use the term Sjögren's all the time. So Sjögren's is actually a separate autoimmune disease, which is immune damage to the tear ducts, the salivary glands and the joints. PBC patients don't actually get Sjögren's because you don't get the antibodies of Sjögren's, but you get a similar distribution of injury. And the joint discomfort often goes with the dry eyes and dry mouth. So the three tend to go together. The good news about it is that this is well controlled usually by simple analgesia, regular paracetamol and Brufen. And there's a myth out there you can't take Brufen and related drugs with PBC. And I don't know where that comes from. The only exception for that is after transplant. If you're taking tacrolimus or cyclosporin, you can't then, but otherwise there's no problem with those. The secret with those is if you get the joint discomfort every day, don't wait for yourself to get the joint discomfort. Take your analgesia first thing in the morning, and most of all, keep mobile with it. So it is not usually a problem. Over time, as you get the treatment, better sorted out with PBC, in our experience, it tends to become less and less. So this combination, so you get bone pain, you get joint pain, and this allows you to tell you one of my favorite jokes. As a physician, one likes to gently rib, shall we say, one's surgical colleague. So there are a number of jokes that we use, but one of my favorite one is what's the definition of a holistic orthopedic surgeon? One who's interested in the whole bone and not just the joint. So there you go. Boom, boom.
Okay, next question. Background is patient has had PBC for 15 years and is on Urso. Levels are reasonable. They have acid reflux and on Nexium 10 daily. In the last few months, their folate has dropped below the low end of the range. Could this be related to the PBC or Nexium? And they've noted that they don't have any.
What's dropped below the lower limit?
Folate.
Oh, okay. No, it won't be. It will simply be amount going in. So if folate is low, just get a folate supplement. It's one of the things. It's easier to. It's not difficult to be folate deficient in your diet because the things that have a lot of folic acid in them are not necessarily the things people would instantly put at the top of their list of the things they want to eat. Let's put it that way. So folic acid is a dietary thing. So just take a folate supplement. Or if you're going to take a general multivitamin, just check there's folate in it. But I mean, for obvious reasons to do with pregnancy, folic acid is pretty easily available. Just can I pick up on a question, a comment from Celia about magnesium prevents muscle cramps, and it absolutely does. And I can, the personal experience of one D Jones is that really bad muscle cramps are really effectively treated by magnesium. And the reason is that your muscle gets a bit hypersensitive with cramp. So what's happening is the muscle is firing off when it's kind of not appropriate for it to do. It goes back to what I said before, which is that you need calcium to be able to control muscle function, except calcium is normal because we normalize it, but you also need magnesium. Whenever you talk about calcium, think about magnesium. And so that is another reason to think about magnesium. So I can testify from personal experience. I was on holiday. I was on holiday in Scotland the week before last, and we were up in Orkney, and then we went to West Highlands and Skye. And my tent is somewhere in the North Atlantic now, where it was taken away by the ever so glorious wet weather we had the week before last. I've literally never known so much rain in all my life. It's my first ever visit to Scotland, other than to the foundation in Edinburgh, and it never stopped raining the entire time. There you go. So, and
beautiful though.
Yeah. Oh yeah. No. Lovely. But in the midst of this terrible weather, I got horrible cramps, and my wife is an intensive care person, and she went off and got magnesium, and it just cured it like that. So I know that that's just an anecdote, but it really made a difference to me. It's quite cold in Scotland when your tents disappeared into the North Atlantic.
I can imagine. Yes. We've got on to the next question. We've got a patient who's saying their white blood cells are very low, so they've been cut. Their rifampicin has been cut down. Is this likely to cause more problems with itch?
Okay, so white cells. So the white cells are the cells that fight infection in your blood. Red cells are the ones that have hemoglobin. So they are all the infection fighting cells. And there are a number of reasons why your white cell count would fall. It could be the white cells being used up because you've got an infection. It could be that your spleen has got bigger as part of progressing PBC, and the white cells are hiding in the spleen. it can be you just run a low white cell count. It's one of those things that crops up all the time in people's tests, and people, end up looking for causes and often don't find them. So it's one to be aware of and to think about, and not overreact to, but you need to kind of try and understand what it is. It also depends on how low it is, because just below the lower limit of normal is just kind of part of the normal fluctuation. So there are situations when it's important if there's a problem with the bone marrow. However, an important cause of it is drugs, and it's one of the things that drugs can do in general. So all drugs have benefits, otherwise we wouldn't use them, but they also have side effects, and it's the balance of benefits and side effects determines whether we use them. So there are certain things you look out for: kidney function, liver function, the cells in the cells in the blood. So if you've got somebody who's on rifampicin and has low white cell count, are the two linked? Well, we've used rifampicin an awful lot, probably more than anybody else, because of the symptoms interest, and it's not a problem we've seen. So that doesn't mean it doesn't exist, but it's kind of not on our list of things that we worry about. It's not, if somebody's going to have a problem with rifampicin, it is usually nausea and vomiting, GI disturbance, or liver tests getting worse. Okay, so that's what it tends to do. Mm-hmm. So is it a coincidence, or is it rifampicin causing the white cell fall? The key with that is to look at the timing of it all. So if you've been on rifampicin for 20 years at the same dose and this happens, it's not the rifampicin. That's not how these sorts of things work. If, however, you've just started it, or the dose has just been increased and it's kind of within a few weeks of doing that, then it's certainly possible. If in doubt about a drug, it's always important to either rein the drug back or stop it. So if in doubt, stop it, see what happens. And of course, if the white cell count was low because of the rifampicin, it will then go back to normal when you're off the rifampicin. So that there's what we call an on phenomenon, which is the problem arises when you take the tablet. And then there's an off phenomenon, which is it goes away when you stop taking the tablet. And that's also important to work out if it's there. And then if you really want, confirmation, you give the tablet again and see if the effect happens again. So that's what you tend to do. But safety first, you discontinue it. Rifampicin is a funny one. It's a very effective drug for PBC itch. We use it a lot, but it's a bit of what we call a dirty drug. So it does have odds and sods of side effects. And so, it's not uncommon to get these sorts of things. So if in doubt, cut it back or stop it and see what happens. What we do find is that rifampicin is a switch for itch. So we get I've had people who've had rifampicin for 20 years, complete control of the itch, decide not to take it anymore because the itch has gone away, and 2 days later the itch is back. So it just switches it off. And so as soon as you stop taking it, the itch will come back. Now, I think there are some other options for people who are well controlled with rifampicin and for whatever reason don't want to take it. So there are some other options. So it's just one of a number of things. So if in doubt, stop it, wait and see. And then if the problem with the white cell counts continues, it's not, clearly not rifampicin. And then whether you need a therapy and what that therapy is slightly depends on, the other things that are going on. So my money would be, if somebody phoned me up and said somebody's got a low white count, they're on rifampicin, my gut feeling would be it wasn't that. But that's just a gut feeling. And, there's a first time for everything. There was a very famous radio phone-in not so long ago where a politician, don't we all love them, a politician came on and was trying to explain, how very, 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 very unlikely something was. And just to emphasize that this is incredibly unlikely, and use the unfortunate example of it's a little bit like being struck by lightning twice, at which point this guy phoned the phone in and said, that's reassuring for most people, but not for me, because I've been struck by lightning twice. So, lightning does strike people twice sometimes. So hence precautionary principle.
Okay. I'm going to wrap it up there for today. I think we've probably got enough questions that we could continue for another hour, but I'm going to have to wrap it up today because I've got another commitment at 3 today. But thank you so much. Thank you so much for joining us today, Dave, and for everyone who submitted questions in there, either on Facebook or that haven't been asked. I'll make sure they're captured for our next session as well. If you need more urgent advice, please just give us a call on the helpline number. We're always there to answer questions quicker if you need us. So thanks very much, Dave. We really appreciate your time today.
Absolute pleasure.
Been lovely to see you. Take care and we'll see you next time.
You're much better than the last bloke. I don't know who he was. I'm glad you got rid of him.
I'll let him know that. I'll pass that on.
Much better. Don't know who he was. Don't bother with him again.
Right, take care. See you later. Bye.
Bye, everybody.